Diabetes mellitus is one of the most complex and most common disorders in the nation, affecting tens of millions of Americans. But many of them don't realize that they have diabetes, so the disorder goes unrecognized until the patient seeks care for another problem, such as blurred vision. Yet because diabetes can affect virtually all body systems, the patient runs a high risk of developing a life-threatening or debilitating complication even before the disease is diagnosed. That's why you need to be able to spot the clues that point to diabetes. For example, this patient was just admitted to the emergency department. He's lethargic and confused, and his breath has a strong alcohol-like odor. Although you might think alcohol intoxication is the cause of this patient's condition, you should also suspect diabetic ketoacidosis, or DKA, as the cause. But do you know why? Can you relate this patient's assessment findings to the pathophysiology of diabetes? And do you know how your interventions can help him control the disorder? This program will help you answer these questions with confidence. It will clearly explain the pathophysiology of diabetes, show you how to identify and control the disorder, and demonstrate ways to recognize and prevent its complications. Diabetes mellitus is characterized by insulin deficiency, which alters the metabolism of glucose, the body's main source of energy. Before you can manage diabetes and its complications, you need to understand normal glucose metabolism. Normally, insulin is produced in the pancreas by beta cells in the islets of Langerhans. Insulin lowers the blood glucose in 3 ways. First, it shifts glucose from the bloodstream into the body's cells by binding to insulin receptors on the cell's membrane. Once bound, insulin and the attached receptor move into a cell, creating an entryway for glucose. Second, insulin promotes the storage of excess glucose. To do this, it activates the enzyme glucokinase, which breaks down glucose into glucose 6-phosphate, or G6P. Then, insulin activates glycogen synthase. This enzyme converts G6P into glycogen, which is stored in the liver and muscles. Third, when the glycogen stores are full, insulin stimulates the enzyme, lipoprotein lipase, to convert excess glucose into free fatty acids. These fatty acids are absorbed by fat cells, where they combine with glycerol 3-phosphate, or G3P, to form triglycerides. 2 major types of diabetes mellitus have been identified, but each develops differently. Type 1 diabetes is characterized by the destruction of all beta cells. In immune-mediated type 1 diabetes, or type 1A, the immune system recognizes beta cells as foreign and slowly destroys them. This type 1A accounts for over 90% of type 1 diabetes cases. In idiopathic type 1 diabetes, or type 1B, the cause of beta cell destruction is unknown. Type 1B accounts for less than 10% of type 1 diabetes cases. In both forms of type 1 diabetes, insulin production eventually comes to a halt. Without insulin, the patient develops hyperglycemia, or excess blood glucose. Type 2 diabetes is characterized by decreased insulin production, cell resistance to insulin, or both. Decreased insulin production usually occurs with age. In fact, the risk of developing type 2 diabetes increases with each decade of life. Insulin resistance occurs when insulin receptors have difficulty recognizing insulin molecules. As a result, fewer insulin molecules bind to receptor sites, allowing fewer glucose molecules to enter the cells. Several factors may increase the risk of developing insulin resistance. A family history of type 2 diabetes, or an ethnic background that's African American, Hispanic, or Native American, may increase the risk because of genetic factors. Obesity raises the risk because it increases the number of fat cells. and the receptors on fat cells resist insulin more than the receptors on other cells. A sedentary lifestyle can compound the risk because the patient doesn't gain the benefit of regular exercise, which lowers the cell's insulin resistance and helps prevent obesity. To compensate for insulin resistance, beta cells produce more insulin. At first, this helps glucose enter the body's cells, lowering the blood glucose level. Eventually, the beta cells become overworked and produce less insulin. This reduces the amount of glucose that enters the cells, causing the blood glucose level to rise. Without treatment, severe complications can occur. An acute complication, DKA, typically strikes patients with type 1 diabetes who don't take insulin as prescribed or who have an illness such as pneumonia. The stress of illness increases the secretion of hormones such as epinephrine, norepinephrine, and glucagon. These hormones raise the blood glucose level by increasing glucose production or reducing glucose movement into muscle cells. Then glucose builds up in the blood because it can't enter the cells without insulin. The cells soon become starved for glucose to fuel metabolism. So the brain signals the alpha cells in the pancreas to produce the hormone glucagon, which converts glycogen into glucose in the liver. When the glycogen stores are depleted, the liver converts free fatty acids and protein into glucose, raising the blood glucose level even further. The conversion of free fatty acids into glucose creates ketones as a byproduct. Because ketones are acidic, they disturb the acid-base balance when they accumulate in the blood. Eventually, ketone accumulation and hyperglycemia lead to DKA, a type of metabolic acidosis. If you suspect DKA in your type 1 diabetic patient, assess him quickly so that you can provide appropriate critical care. First, measure your patient's blood glucose level and repeat this measurement at least every hour until his condition is stable. In DKA, the glucose level typically exceeds 300 milligrams per deciliter. Also, check your patient's urine for ketones, which appear in DKA. Remember to recheck for them every 2 to 4 hours or as ordered until they're no longer present in the urine. Next, obtain blood samples to assess fluid, electrolyte, and arterial blood gas or ABG levels, which you'll review later. Then check for signs of fluid and electrolyte imbalances. You're likely to detect signs of dehydration, such as poor skin turgor and dry skin and mucous membranes. You're also likely to see signs of electrolyte imbalances, such as cardiac arrhythmias. In DKA, severe fluid and electrolyte loss usually results from osmotic diuresis. When the blood glucose level rises, the kidneys try to compensate by excreting excess glucose, which takes water, sodium, potassium, and other electrolytes with it. As large amounts of fluid move from the intravascular space into the urine, the blood volume decreases. At first, this hemoconcentration causes falsely elevated electrolyte levels. However, when the fluid is replaced, the blood becomes less concentrated. This makes the electrolyte levels fall, often to below normal levels. Next, take the patient's vital signs, being alert for Kussmaul's respirations. These rapid, deep respirations develop when the lungs try to remove excess acid by exhaling additional carbon dioxide. And because the acidosis is caused by ketones, the patient's breath smells sweet and like alcohol. Also, check for low blood pressure and tachycardia. Low blood pressure results from low blood volume, and tachycardia occurs when the body tries to raise cardiac output while the blood volume is low. Now assess for signs of GI complications, such as decreased or absent bowel sounds, nausea, vomiting, and abdominal pain or tenderness. GI complications are common in DKA because metabolic acidosis slows intestinal function, which may lead to paralytic ileus or intestinal paralysis. When the test results are ready, check the ABG levels. DKA typically causes a partial pressure of carbon dioxide, or PCO2, of less than 35 millimeters of mercury, indicating the lungs attempt to compensate, a bicarbonate level of less than 28 milliequivalents per liter, indicating the kidneys attempt to compensate, and a pH of less than 7.35, indicating acidosis. To treat DKA, first replace the lost fluid with normal saline. Administer each liter over 30 to 60 minutes as prescribed. During fluid replacement, recheck the electrolyte levels every hour and administer specific electrolytes as needed. If your patient's pH level is below 7, start a bicarbonate infusion as prescribed. To prevent rebound alkalosis, be sure to infuse it slowly. To lower the patient's glucose level, expect to administer insulin intravenously. After administering a bolus of regular insulin of 0.15 units per kilogram, begin a continuous infusion of 0.1 units per kilogram per hour and adjust it based on the blood glucose level. During insulin therapy, monitor your patient's glucose level closely. Make sure that it doesn't fall faster than 100 milligrams per deciliter per hour, because this can cause complications. How? As glucose moves from the blood into the cells, it takes water with it. This may cause cellular edema and organ swelling. If swelling affects the brain, increased intracranial pressure may lead to herniation and death. Also, watch for early signs of hypoglycemia or low blood glucose, such as diaphoresis, tachycardia, and tremors. In this dangerous complication, the blood glucose level falls below 60 milligrams per deciliter. When intracellular glucose levels fall, the brain signals the alpha cells in the islets of Langerhans to secrete the hormone glucagon. Glucagon causes glycogenolysis by triggering enzymes to break glycogen into glucose. Glucagon also causes gluconeogenesis by stimulating the conversion of protein and free fatty acids into new glycogen. The brain also signals the adrenal glands to release epinephrine, which prompts the breakdown of glycogen and fats to glucose. The release of epinephrine causes the early autonomic signs of hypoglycemia, such as diaphoresis, tremors, and tachycardia. If the blood glucose level continues to fall, the patient develops late neuroleptic signs of hypoglycemia, including poor coordination, slowed thinking, and loss of consciousness. If your patient has hypoglycemia, is conscious, and can swallow, provide 15 grams of an easily absorbed carbohydrate, such as 4 ounces of orange juice. Repeat this treatment every 15 minutes until his hypoglycemia resolves. If your hypoglycemic patient is unconscious or can't swallow, administer 25 to 50 grams of dextrose 50% in water by IV bolus. If he doesn't have an IV access device, inject glucagon intramuscularly. Remember to turn the patient on his side to prevent aspiration, because glucagon can cause vomiting. To prevent hypoglycemia, change the IV solution to dextrose 5% in water and half normal saline when the patient's glucose level falls below 250 milligrams per deciliter. If your patient with DKA has abdominal pain, nausea, vomiting, and absent bowel sounds, give him nothing by mouth, and prepare to insert a nasogastric tube to relieve distension. Once your patient's condition is stable, perform a complete physical assessment. First, obtain a full description of his symptoms. Your patient is likely to report polydipsia, or increased thirst, polyuria, or excess urine output, polyphagia, or increased hunger, and weight loss. All of these classic effects of diabetes are caused by hyperglycemia. Polydipsia results from dehydration. As excess water is excreted in the urine, the fluid volume decreases. Then the brain's thirst mechanism alerts the patient to drink more fluid. Polyuria results from osmotic diuresis. As the blood glucose level rises, the kidneys try to compensate by excreting glucose into the urine. Because glucose is a large molecule, it pulls water with it. This produces large amounts of dilute urine. Polyphagia stems from cellular glucose deprivation. Because glucose can't enter the cells, they signal the brain's appetite center to increase food intake. But eating more food worsens the hyperglycemia by causing more glucose to enter the blood from the GI tract. Weight loss is caused by dehydration and fat breakdown. The latter occurs when the glycogen stores are depleted and the cells, desperate for fuel, signal the liver to convert fat to glucose. Also ask about other signs of hyperglycemia, including frequent infections, vision disturbances, and paresthesias in the hands and feet. Among diabetic patients, common infections typically include those of the skin, urinary tract, vagina, and any wounds. No one knows exactly why diabetes increases the risk of infection. However, some experts believe that hyperglycemia impairs phagocytosis, which is microorganism destruction by white blood cells. Others believe that hyperglycemia and acidosis lead to infection by creating an environment that promotes microorganism overgrowth. Diabetes may cause vision disturbances, such as blurred vision, because hyperglycemia alters eye structures, such as the lens, aqueous humor, and cornea. Paresthesias occur when excess glucose coats the nerve fibers. Over time, the coating interferes with nerve function, causing abnormalities such as numbness and tingling in the hands and feet. Finally, assess your patient for signs of chronic complications of diabetes, which can affect nearly all of the body's organs. That's because uncontrolled hyperglycemia damages the arteries that supply those organs with blood. Here's how. First, hyperglycemia increases the risk of hypertension and hyperlipidemia. In the arteries, these conditions tend to injure the endothelial lining, allowing lipids to invade it. Second, hyperglycemia and other factors lead to smooth muscle cell proliferation in the injured arteries. This narrows the arterial lumen. And third, hyperglycemia makes platelets stickier, which increases platelet aggregation at the injury site. This impedes blood flow even further. All three events raise the blood pressure and impair blood circulation by increasing arterial resistance. Most chronic complications of diabetes are macrovascular or microvascular. Macrovascular complications result from changes in large blood vessels. To detect them, assess for signs of heart disease, especially coronary artery disease, cerebrovascular disease, such as cerebrovascular accident, and peripheral vascular disease, such as arterial occlusive disease, which can lead to foot ulcers. Microvascular complications stem from changes in small blood vessels. To spot them, be alert for signs of retinal disease, kidney disease, and nerve disorders. To evaluate the effectiveness of treatment, prepare your patient for diagnostic tests. When the tests are completed, review the results. In a diabetic patient, the blood glucose test is likely to show a level that exceeds 126 milligrams per deciliter on a fasting glucose test and 200 milligrams per deciliter on a 2-hour postprandial glucose test. In a patient without diabetes, the glycosylated hemoglobin test shows that 4 to 6% of glucose is bound to hemoglobin. In a diabetic patient, the percentage may be higher. For example, 7% is equivalent to a mean capillary blood glucose level of 154 milligrams per deciliter. In poorly controlled diabetes, the blood glucose level remains higher for a longer time, allowing more glucose to bind to hemoglobin in red blood cells. The glycosylated hemoglobin test reflects glucose control and treatment compliance over several months, because glucose stays bound to hemoglobin for the red blood cell's entire lifespan, which is several months. The urine ketone test may show ketones in the urine. When accompanied by a high blood glucose level, this is abnormal and signals ketoacidosis. After reviewing the test results and other findings with the patient's physician, work together to maximize the effectiveness of the treatment plan. Then discuss the plan with your patient. Treatment for diabetes mellitus consists of drugs, diet, and exercise. A patient with type 1 diabetes typically receives insulin subcutaneously every day to control his blood glucose level. Because this drug mimics endogenous insulin, it promotes glucose storage and helps prevent the breakdown of glycogen, protein, and fat. Depending on your patient's response, he may need insulin that is rapid-acting, short-acting, intermediate-acting, long-acting, or a combination. A balanced diet is a vital part of therapy for type 1 diabetes. Your diabetic patient should eat a diet that provides nutrients from all food groups, is low in sodium and cholesterol, and is high in fiber. A balanced diet typically includes 50 to 55% carbohydrates, 30 to 35% fat, and 10 to 20% protein. Your patient also should follow a regular exercise program to enhance the body's use of insulin. This patient with type 2 diabetes mellitus was admitted to your unit today for treatment of pneumonia. During your rounds, you notice that she's lethargic and difficult to arouse. You suspect that she may have hyperglycemic hyperosmolar state, or HHS, an acute complication of type 2 diabetes mellitus. In a type 2 diabetic patient, surgery or another stressor increases the body's need for insulin. Because such a patient can't produce extra insulin or use it effectively, the cells don't receive enough glucose for energy. Insufficient intracellular glucose triggers gluconeogenesis, which converts fat and protein into the glucose that the cells need. But without sufficient insulin to help glucose move into the cells, the blood glucose level climbs. If untreated, HHS occurs, raising the blood glucose level dramatically. However, HHS does not cause ketosis. That may be because the pancreas still produces some insulin, which prevents the breakdown of fat into ketones. However, the pancreas doesn't produce enough insulin, which means that too little glucose reaches the cells, and this causes the liver to convert glycogen into glucose, raising the glucose level even higher than in DKA. That's why HHS causes severe dehydration and neurologic dysfunction. HHS requires critical care and prompt treatment. So if you suspect this condition, work quickly to assess the patient and intervene rapidly. First, check the blood glucose and urine ketone levels. In a patient with HHS, expect the blood glucose level to exceed 600 milligrams per deciliter. Next, assess the patient for signs of fluid and electrolyte imbalances, which occur when the kidneys excrete water and electrolytes along with glucose. Then replace the lost fluid by administering normal saline at the prescribed rate. During fluid replacement therapy, monitor the patient's urine output closely. When it reaches 60 milliliters per hour, expect to switch to half-normal saline solution to prevent hypernatremia. Plan to administer insulin as prescribed, usually at 0.1 units per kilogram per hour. When the patient's blood glucose level reaches 250 milligrams per deciliter, prevent hypoglycemia by switching to an IV solution that contains dextrose. As fluids are replaced, check the electrolyte levels and administer electrolytes if needed. When the patient's condition is stable, perform a complete assessment and review all test results as you would for a patient recovering from DKA. Be alert for signs of diabetes and its chronic complications. Also discuss your findings and the treatment plan with the physician and your patient. If a balanced diet and regular exercise don't control the blood glucose level, your type 2 diabetic patient may need drug therapy. Occasionally, she may need insulin, but typically she will start with an oral hypoglycemic drug. Sulfonylureas, such as glyburide, stimulate beta cells to produce more insulin, as do megliteinide analogs, such as repaglinide, and D-phenylalanine derivatives, such as nateglinide. They also increase cell receptor sensitivity to insulin in peripheral tissues, which allows more insulin to bind with insulin receptors. Both mechanisms let more glucose enter the cells, which lowers the blood glucose level. Like sulfonylureas, biguanides such as metformin increase cell receptor sensitivity to insulin. In addition, they suppress glycogen formation in the liver, which reduces gluconeogenesis. Alpha-glucosidase inhibitors, such as acarbose and miglitol, delay carbohydrate breakdown and GI tract absorption, which lowers the blood glucose level. Thiazolidinediones, such as pioglitazone, sensitize peripheral tissues to insulin. Incretins, such as exenatide and sitagliptin, stimulate insulin secretion and suppress glucagon secretion. Another drug, pramlintide, delays gastric emptying, suppresses glucagon secretion, and decreases appetite. When used in combination therapy, these drugs may let the patient receive smaller dosages of other oral hypoglycemics or insulin. Whether your patient is recovering from DKA or HHS, individualize her nursing care, but expect to perform these general nursing interventions. Check the patient's blood glucose and urine ketone levels at least every 4 hours. Assess electrolyte and ABG levels as well as the results of other tests. Monitor the patient's fluid intake and output to evaluate fluid replacement. Watch for signs of complications such as hypoglycemia, and ensure that the patient receives a balanced diet. Before your patient is discharged, teach her and her family how to control diabetes and prevent complications. Be sure to cover medication use and side effects, diet and exercise changes, blood glucose and urine ketone testing, signs, symptoms, and treatment of hyperglycemia and hypoglycemia, health maintenance activities such as eye and foot care, and follow-up care. As you have just seen, diabetes mellitus is a complex disorder that affects all body systems. If uncontrolled, it can lead to life-threatening complications, such as DKA and HHS. By understanding the pathophysiology of diabetes, you can recognize its complications swiftly and accurately, intervene with confidence, evaluate the treatment's effectiveness expertly, and help your patient control the disorder. Armed with this knowledge, you can provide the best possible care for your patient and help her live longer and better with diabetes.